Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. On back to another episode. Today I'm with Dr. Vic Martel. He is a general dentist practicing in Florida. Vic, thank you for doing yet another episode with us.
Well, thanks for having me. Hopefully this topic will hit at the hearts of a lot of the surgeons, because I know this can be a pain point for some of them. So I think it's something that will help a lot. So I'll let you get started.
Yeah, that's a good lead in here. The topic is implants and occlusion. This definitely is one of those potentially frustrating things for us as surgeons, because it's one of those things we can't control to some degree, at least not directly with our own hands. And so I think this will be a good topic to maybe educate us more on occlusion, know how we can educate our dentists and those that are prosthodontists doing the occlusion. How would you define quote unquote occlusion in the context of implant dentistry?
Wow, that's a big question. So to give you a little background so that everybody kind of knows where I'm coming from, I was trained, I did all of Dawson. I was actually visiting faculty at Dawson Center for a few years, was trained with Spear, and also got trained, may he rest in peace, prosthetically by Carl Misch. I did a lot of his prosthetic work. So if I were, and I teach occlusion courses, and the reason that I'm leading up to this is, if I were to define occlusion for implants, and in reality of it, if I were going to define occlusion, period, the simplest way of defining it is load sharing. How do you share load? Because if the load is shared evenly, we have far less problems. If the load is shared unevenly, we have far more problems. With implant dentistry, a lot of restorative dentists, I'm not sure about surgeons because you can only speak to them, they're under this illusion, I guess is the proper word for it, that, well, this thing's integrated, so it should be fine. And in essence, implant occlusion is probably more important than occlusion on teeth, because there's quite a few more things that can go wrong, and none of them are good. So load sharing is the idea of what we're talking about here. So,
got it. Okay, that's a good way to put it. So, I mean, if you ask the surgeon about the occlusion, most, as in like, if you ask the surgeon, what type of occlusion do you think an implant crown should have on it, or how would you counsel your new, let's say new grad dentist who's going to be restoring this implant? I think most of us would say to the dentist who's brand new doing their first implant crown, let's do a very light occlusion, and kind of explain how there's no PDL around an implant, it's not going to move, and all that type of stuff, so that you want that crown a little bit shorter than the adjacent crown, so when you bite hard, it doesn't, boom, take all the impact. But what are your thoughts on?
So to give you a little background, when I do my normal circ programs, my whole continuum, about half a day a lecture, and I started to do this myself. This wasn't something I learned from anybody else, and it's because I have, probably, for lack of a better way of saying it, I have an occlusion bias, meaning everything I do, because of the way I was trained, is centered around occlusion. So I would actually start talking about occlusion maybe during, remember if we referred to in previous episodes of grand rounds and things like that, but I always addressed the occlusion in that. So what happened over time was, every time during the breaks and things, I would get questions about occlusion. And so over time, I actually developed about a half a day of one of my sessions purely dedicated to occlusion, because I noticed that this was a very lacking topic that people talk about a lot. Grant, as a surgeon, you deal with all these restorative dentists, and you are completely, for lack of a better way of saying it, at their mercy, at their occlusion knowledge. You put your implant in, it's integrated, everything's fine, and now all of a sudden you send it out, and everything's different once that person restores it. So to give you the really simple answer for a one tooth, let's say it's tooth number 30. What I stress is this, and you just said it real quickly, but and I think everybody that's listening, your audiences know this already, but it's super important for them to be able to share this with their restorative dentist, because not all of them know this. Is we know that every natural tooth has a PDL. Not only does it have a PDL, it has mechanoreceptors and proprioception. It has a sense of position. Your implant doesn't. It's ankylosed. Mm-hmm. So when I do the occlusion on an implant crown, now we maybe refer to this later. It also depends, believe it or not, on whether it's a cementable crown or a screw retained crown. Even the occlusion slightly changes on one of those, and that's super important to understand. But from a general standpoint, what I want, and I teach, is I want the dentist to check the occlusion in a normal closure without clenching, and the shim stock should pull through. Okay. Very, like just ever so slightly be able to pull it through. And then when the patient clenches, it should stick. Why? Because when everybody at some point in their life during a day, a human being clenches. And when a human being clenches, the other two teeth, because they have PDLs, they move out of the way. They go down. Mm-hmm. And if everything is even occlusion, what's happening is if the patient clenches and the teeth move downward, or in other words, in a lower position, the only thing taking the load at that point is your molar, is your implant. And we don't want that. So we want to set the occlusion so that when a patient clenches and the teeth move down, now the teeth and the implant get load evenly. And the only way to do that is to have the implant crown in a slightly under occlusion in a normal closure. And you're going to get this question, well, isn't the upper tooth going to extrude? Believe it or not, no. And the reason is that during the day, because the human being closes and clenches multiple times a day, the teeth don't shift that much. So ultimately, we're not going to have that, because at some point in the day, we're going to have contact with that implant crown for any kind of clench at all. So therefore, the opposing tooth isn't going to migrate, and something where you're going to have to worry about it. But that's the simplest part of the occlusion. And I teach this every day. And the reason is knowing these kinds of things help with, number one, simple things like, we've mentioned this before, broken screws. May sound minor, but to the surgeon, it's not fun because you're usually the ones retrieving it. That's just part of your day. Chipped porcelain, believe it or not, can be worse than a broken screw. And the reason is the minute you chip porcelain on an implant crown, the occlusion changes, because that part of the tooth was hitting first, don't forget, and now it's not. So something has to hit first now, and now we end up seeing a problem. Worst case scenario is we lose integration. To give you some really many, many years ago background, when I was getting trained by Carl Misch in his prosthetic programs, Dr. Misch would always say that if an implant post-restoratively failed within the first 18 months, it's 100% occlusion. Now, I'm not that dogmatic. I wouldn't say it's 100. It's probably very close, okay? And the reason is you released the patient, the implant was integrated. Something changed, okay? Mm-hmm. So, when during my courses, I always, it's kind of a joke, but I say, what's the top 3 reasons an implant fails? And they say, occlusion. I go, you're right. I go, what's number 2? And they say cement. I go, no, it's occlusion. What's number 3? It's occlusion. What's number 4? Probably cement. Okay. So occlusion is that important at the level where what Grant Stucki would like every day is to release all his implant patients, never have a broken screw, never have a problem. Everything's great. And because solving problems becomes not only expensive, it becomes very time consuming and interfering in your schedule and things like that. So that's something we try to avoid. And that one single tooth implant case, which is probably the most common, right? Because there's more single tooth implants than there are full arch implants. But ultimately, that's something that if the general or the restorative dentist learns that first, they're going to be much more less much more likely to have successful implant cases, meaning no broken screws and things like that. So that's the start of occlusion. I could talk about this for about 3 days, but we can just, I know we can cover this as much as we can. So.
And then the next question is how you manage the axial loading forces on an implant. I mean, as we know, we try our best to get those implants totally perpendicular to the plane of the bone and the bite, but sometimes they're angled a little bit. Is there anything
Right.
you can do to manage that so the force is going on the center of that implant?
Yeah, and that's really, Grant, that's super important. And here's why. And this is where things tend to get a little shaky when it comes to let's go here first, because this is the most common angulation issue, is a full arch case. Let's say it's an all-on-4. I use all-on-6, but it doesn't really matter. All-on-4, and you're angling implants. Okay? And the reason, every surgeon knows this already. The reason you're angling implants is because you're trying to increase the anterior posterior spread, right? But here's the challenge. If you and I were doing a case and I knew for whatever reason you're going to angle implants, whether it's you're trying to increase the AP spread, you're trying to avoid a sinus lift for whatever reason, okay? The challenge with that is those angled implants aren't getting loaded down the center of the implant.
Right.
It's not an axial load. Now, it's not that there's anything wrong with that, but here's the most important part of it that most dentists, restorative dentists, and maybe surgeons, I don't know, you can tell me if you know this or not. I'm going to tell you, Grant, as the surgeon, I don't mind you angling implants. We're not going to cantilever near as far. Okay? And the reason is the load, as we initially talked about, is still down vertically. And you have an implant sitting up there that the load that implant isn't taking the load vertically. And what happens on those implants is the distal of that implant, that's where you start seeing bone loss.
Right.
So the challenge is, so if you and I were designing a case, and let's say it's an all-on-4 upper case, I would say to you, Grant, okay, I understand you need to angle the implants, but I'm not going to cantilever back as far. So to give you a little background, I'm sure you know this already, but when you calculate anterior posterior spread, Carl Misch would say you can go 1.5 to 2 times that with the cantilever. Now, when you angle implants, I would never tell you can go 1.5 to 2 times back. I would never say that. I would say, okay, maybe you can go the size of a premolar back. We're not going to cantilever really far back. And the reason is you're going to lose bone on the distal just because of the way that implant's being loaded. Okay? I had a good friend just recently up in Ohio, oral surgeon, and this was really interesting. He sent the case to a prosthodontist, angled implants. The gentleman probably did and I'm not exaggerating, it looked like about a 7-8 millimeter cantilever. Case failed. And all it was it was a load issue because the cantilever should have never been that long. So if you and I were doing a case and you want to angle implants, the first question I ask is, hey, Grant, do you think if you angle those distal implants, you can get maybe the implant to come out at about the number 3 position? Maybe 4.5 in that range, because I don't want to cantilever back, maybe a little bit of the size of a premolar back, but I'm not going back as if those implants were vertically inserted into the jaw. Okay, then I can use that formula of 1.5 to 2 times, but not when they're angled. I think it's a very important difference because, again, it's all about load. So,
yeah, that's good to hear. And useful information for cantilevering teeth. When we hand over our patients and we just kind of trust, like you're saying, that they do the occlusion perfectly. I mean, what are the I don't know, do you have a list of points or things that should be checked? You mentioned the shim stock and pulling it through, but what other things do you want that dentist to really make sure before the patient walks out of the office with the new crown?
Yeah, I think the reason I'm hesitating is I'm trying to say this diplomatically. I think the biggest thing that dentists miss is they don't check lateral excursions.
Okay.
You know, here's what I would, and here's how I would do it. I don't want to give you a cookbook, but number one, obviously the shim stock pull, and then in a clench, it catches. That's in normal occlusion. But here's where the next step gets missed. After I'm done with that, I'm going to put a piece of articulating paper in, and I'm going to have them clench again. And then I'm going to have them move left, move right, and move forward into protrusive. I want zero contact on my implant. Zero. Because don't forget, the enemy of an implant is lateral forces. Period. Okay? So we can't have those. So ultimately, yes, check it with shim stock. Yes, check it, but you have to go into left lateral, right lateral, protrusive, and I want zero contact on that implant. I want the teeth that have the PDL and proprioception to take the load, not the implant. And ultimately, that's my final step. There's many things that we check as the months and years go by, but and then I should tell you this. 90% of dentists, maybe 95% of dentists, always check an implant crown or any crown. This is really helpful for all crowns, but definitely for an implant crown. Grant, when you see what position do you think a patient's in when the dentist is checking occlusion? They're laying back.
Correct. Yeah.
They don't check it when the patient's sitting up. You have to. Okay. And the reason is when a patient's laying back, their jaw becomes more retrusive, right? So because the lateral pterygoids kind of release a little bit.
Yeah.
And so I'll do shim stock, right and left protrusive, and then I sit the patient up, and then I check it again. You don't know this because you're not a general dentist, but every general dentist would appreciate this, and you can talk to your referrals about this. Many times you'll see the crown on a patient, you say everything looks good, and then as soon as you sit them up, they go, oh no, it still feels high.
Yeah.
That's because what happened was from the point of about 60% of patients, their position of their jaw changes from laying back to moving forward to sitting up. So what I do is sit them up. How does that feel? Feels great? Let's check it one more time. And if I see anything but that one in a cementable crown, that one dot in the center of the implant, I'm going to adjust it. So those are the things I do every time I see an implant case. And knock on wood, I think maybe in all the years I practiced full time, I think I had two loose screws. Never had a broken screw. But it's because I'm a little bit OCD about occlusion, probably. Maybe there's other things involved too, but that's just how I do it.
Nice. And then I'm sure there's also, if it's cement retained, really making sure you clean that margin and it's looking great.
Yeah, but here's the thing, and let me ask you this, Grant. I mean, I would assume most of your cases now, I don't know how often you see them post-restoratively, but most cases now are screw retained.
Right, for sure.
Hopefully.
Yeah.
We could have a whole other topic on cements and why certain cements are better than other cements. And if you're going to cement at all, I probably have done screw retain now exclusively for the last 6-7 years. Why? Because, peri-implantitis is that's a whole other topic. But here's the interesting difference. When an implant is screw retained, you can't have the occlusion straight down the center of the implant. Why? Because that's where your access hole is. Well, what's the problem with an access hole? It's composite. What's the problem with composite? It wears.
Yeah.
So your occlusion becomes less stable if you have it exactly down the center of the implant, and that contact is in composite. So if you can imagine in your mind's eye, if the screw hole's in the center, I want one dot to the anterior and one dot to the posterior of the screw hole.
Right.
In other words, I want it on porcelain. I don't want it on the composite. When it's a cementable, we go straight down the center. Okay, meaning right over where a screw hole would technically be. But when it's a screw retain, which is most things today, I want a dot in front and I want a dot behind the screw hole. And then everything else is the same: shim stock, excursions, protrusive, and sitting up and sitting back. So those are all the things. It sounds a lot more complicated than it is, because dentists are going to do this in 5 minutes, but it becomes something that's super important. A little bit of time makes it super important.
Do you have any tips or thoughts on the tightening of the screw that locks the crown in? Because it's not an uncommon thing for a crown to go on, adjust it, it's great, and then like 2 weeks later, they send it to me. Oh yeah, the crown is loose now, and then it turns out it wasn't a screw that was tight enough. And sometimes those loose screws and the implants wobbling around for like a month or two, and then that just wreaks havoc on the soft tissue, and it can be
Absolutely.
a frustrating situation when that screw loosens or isn't tightened properly.
It really is. When we may be able to talk about this, maybe not. There's a difference in screw tightening when it comes to full arch cases as opposed to, single tooth cases. For example, single tooth cases, obviously the manufacturer has their own, uh, torquing level. It's usually 35 Newton centimeters in that range, or whatever it happens to be for that company. And depending on the size of the screw, right? But I think probably the most common problem that general dentists, what you said, even though you may not have realized you said it, if it comes loose that quickly, and I mean with a matter of weeks, they never torqued it. Meaning they thought they did, but it didn't happen.
Okay.
That's just, and I think nowadays, and I think there's I may have sent it to you. If not, I will send you the link. I think the best thing dentists can do is buy one of the hand pieces that torque, that have different torque levels on it, as opposed to just using the normal torque wrench that Straumann or Biomet or Nobel would hand you, because you can literally just adjust it to the level, and all of them nowadays are calibrated and they're all pretty consistent. So I would tend to want my referrals to torque their screws down. If it says 35 Newton centimeters, you torque it down to 35. You click it to 35, you tighten it. It clicks, it's down. Okay. The other challenge you have, and this is an interesting thing, I don't even know if you're aware of this, Grant. Straumann, and maybe it's changed, but for years and years, Straumann was the only implant company that, if you can picture this, you're tightening, as a dentist, you're tightening your screw with your normal hex wrench or whatever it happens to be. Straumann was the only company that the screw wouldn't even start to tighten unless the abutment is seated. In other words, it would just spin. Okay. Many other companies, Biomet that I happened to work with years ago, I used with Straumann, and some other ones, you may have tightened it, but the abutment may have not have been seated because it's still going to grab. Okay. So the problem with that is what you just said. Yes, maybe they tightened it, but maybe the abutment wasn't fully seated, and ultimately it loosened anyways. I'll give you an example of this. This was a story that I had from one of my programs. I had a dentist after the program started call me up in my office. He happened to be in Florida, and he says, I have a problem with a upper premolar implant crown, and it's come loose 7 times, and the patient's getting very frustrated.
Okay.
So I said to him, do me a favor, take an x-ray and send it to me. He took an x-ray, and I think I hurt his feelings. I said, the abutment's not seated. And he sent me this very unkind email. I've been doing this for so many years, and I know when an abutment's seated and it's not. Well, I said, well, let me do this. Send the patient down to me. It was about an hour away, and let me look at it. Looked at it. Here's the issue. He took the x-ray at an angle that it wasn't seated, but the angle he took, in other words, a bite wing, a parallel perpendicular bite wing, he couldn't see it because he was taking a PA. Well, ultimately, I took a perpendicular bite wing. I saw that it was up about 1 millimeter. Because the tissue, as you know, gets irritated. I had to get the patient numb. I pushed it into place. I tightened the screw. Never came loose again. See how something that simple can lead to a problem? But ultimately, what happened was, unfortunately, because I happened to fix it so quickly, the patient lost complete confidence in the other dentist, even though I tried to, make
Yeah.
it light of it. But ultimately, it gets loose 7 times and I fix it in 2 minutes. That's a problem. So, and the only other way a screw comes loose, but this is usually months later, is an occlusal issue. That's
Okay.
just, so it's either not torqued, the abutment's not seated, or it's an occlusion issue. And occlusion issues are the ones you got to look for, because what will happen in those cases is the restorative dentist will just tighten it up, but you didn't fix the occlusal issue. So guess what happens? The definition of insanity. It's going to come back. Same thing's going to
Yeah.
happen. Or it's going to break, which is worse.
Yeah, and that's what I suspected in most cases is that it's an abutment that's not lined up properly, and then it gets tightened. But and then they think, oh, it's all tight and it's good. But then as they're chewing it over the weeks and months, that abutment starts kind of moving because it's not in that totally sealed down position. And then,
100%.
and then all of a sudden that screw has space to start unraveling. It's
I don't know
interesting.
if you've ever seen that video on YouTube about micro movement. They showed a video, looked like an X-ray. I don't know what they did, but like a live video of how much an abutment moves during chewing. It was amazing.
Really, that's
It's a
cool.
matter of bending and moving. So ultimately, in my hands, when I talk about occlusion and what you're referring to, it's like micro trauma, right? It's
Mhm.
this bending and moving, and that's why it's never quick. That's why sometimes it's a year later or 7 months later or whatever. But and here's the other issue, and this is a big deal, and gets missed a lot. Let's say it's been 6 months and now the screw gets loose.
Hmm.
If you you check the occlusion and you put it and you tighten it. If you don't change the screw, you're screwed. I'm sorry. Because the threads of that screw are no longer the same.
Okay.
Okay.
Interesting.
So here's what I would tell. Here's what I did. And again, I'm telling you, I was a little OCD. I would never allow my lab to send me the screw. I would actually have them take it off my lab bill, and I had a drawer full of brand new unopened screws when I knew I was going to seat the case. Because I don't know how many times they tried it in and took it out and tried it in. So I literally I said, you can send me your lab screw, but don't send me the screw. I open up a package and I use my screw that I know has never been touched before, because you got to remember, a lot of those screws only, especially on the full arch cases, they only have 7 threads.
Yeah.
The thread
Right.
fatigue is huge. So, again, definition of insanity. Well, let me just tighten it down and hope it holds. Well, you don't know the condition of the screw. So now we
Hmm.
have another problem. But all those things are caused by micro traumas, which are occlusion, which is load sharing and things like that. So
Okay. Another question is in regards to, discovering that a patient is like a bruxer or has really bad clenching habits. I mean, is there anything special or different you do for that patient if you discovered that?
yeah, it's actually a very big deal. And here's what I mean. And this comes back to, remember, Grant, when we talked about treatment planning and grand rounds and things. When I look at it in a patient's mouth before the planning of the case, let me give an example in your case. Let's say a patient is missing 18, 19, and 20. Okay. And for the most part, you want to put, normally what we would do there is we would put 2 implants in and 3 in a bridge. Okay. The challenge is not every human is created equal. And ultimately, you might walk in my office and you have these huge masseters. I call it the pyramid head. Your masseters are wider than the top of your head. You're this big dude, and it's just, what I do in those cases is I'm putting 3 implants in. Okay.
Yeah.
Period. I can't depend on, I want to over engineer these cases. And what I mean by over engineer it is from an occlusion standpoint, I over engineer them. I might even call you, if you were my regular surgeon, Grant, I might call you up and go, listen, Grant, this guy's huge. He's got huge masseters. I normally would use 2 implants in a 3-unit bridge. I think we need 3 implants because of that. Let's give the guy a break on I'd rather almost give away the third implant, and I'll do the prosthetics just so that we don't have to redo the case. Okay? Now, what that leads to is also this. I get this question a lot. Do you splint or do you not splint in the posterior? Because that's an occlusion issue again. Now, I'll tell you a funny story with Carl Misch, because I went back and forth with this. And Carl would always teach me to splint crowns because it load shares better, which is what we've been talking about all day. So when I'd kind of go back and forth. Do I splint them? Do I not splint them? This is years ago, I'm having lunch with Carl and a few other people, and he's happened to mention, so Vic, what are you doing? Are you splinting, not splinting, blah, blah, blah. And I go, no, I'm not splinting anymore. He goes, why? Because Carl was very dogmatic, which was great. He's a brilliant man. And I said, well, whatever reason. And I go, and the most important thing is they can't floss. And he looks at me, he goes, they weren't flossing before. What are you worried about? He says, load sharing is more important. Okay. So when you do things in the back, there's multiple other reasons that are good for splinting too. But from a load standing standpoint, if you think about it, if I splint 2 crowns, the crowns are on 2 implants, they're only taking 50% of the load as opposed to 100% of the load. So it's a matter of what we handle in that cases. And ultimately, I want to do, if dentists would think like this, how can I adjust the occlusion or over-engineer the case so that I don't end up with a broken screw and I don't end up with a problem? When I do this lecture, I call it my what ifs. I'm going to adjust everything so that what if something happens? Even if it doesn't. What if a screw goes loose? How can I prevent it? What if I lose integration? How can I prevent it? So ultimately, when you start looking at all those things, the good news is you have much less problems in the future. So,
Yeah, that could probably be a whole nother podcast topic.
yeah,
Is it's like especially that situation where you got 18, 19, 20 missing, and do you do a bridge at 18 and 20 or just 19, 20 or 3, 18, 19, 20? I mean, I have this conversation with patients like every month about where we want to go with that scenario, and is it worth bridging all the way back to the second molar and all this type of stuff, and what are their habits? Are they really going to clean under that bridge? All that type of stuff, is
good point.
going
Yeah.
into it.
I mean, be honest with you. Well, this is my pet peeve, Grant, on the upper, on the maxillary. And this is from an occlusion issue again, I very rarely do second molar implants.
Okay.
It's got to be for a very unusual reason. Okay. Number one, you probably have D3 bone back there, right? D3, D4, whatever it happens to be.
Yeah.
Number two, and this is, I could talk about this because this is a little complex. This is a whole nother thing. But let me go there a little bit, see if I can explain this. On the upper, let's say you put an implant at number 2.
Okay.
Okay. That's one of the most frequently failed implants, an upper second molar implant. And I have surgeons all over the country that just won't do them, and I have surgeons all over the country that do them all the time. Here's what I'm going to tell you. You got to think about this from an occlusion standpoint. And this is just me being me, an occlusion nerd. When a human being lays back, when they fall asleep, let's say all of a sudden Grant falls asleep. What's the first thing that happens? Your jaw relaxes and opens up, right? So you're kind of open-jawed, mouth open, whether you snore or not, your mouth is open. Guess what happens? And I teach this in the occlusion courses. We sleep in cycles of every 90 minutes into REM, right? We go stage 1, 2, 3 for REM. And that's how we do every 90 minutes.
Yeah.
Right before REM, all human beings close. Okay? Now think about this. When you've been relaxed in stage 1 and 2 and 3, the one muscle that causes the problem that moves the jaw is the lateral pterygoid. But because your mouth has been open, your lateral pterygoid is relaxed. So you're retruded every 90 minutes. When you close, the first closure contact is when you're in that retruded position. And guess what you bang on? The second molar. Now, you don't wake up, but your muscles take over, and now you bang and come forward. So if you think about this, your second molar implants on the upper, every 90 minutes is getting this micro trauma of bang, slide, bang, slide, bang, slide. Okay? That's
Yeah.
why sometimes it takes years for a second molar implant to fail. Okay? So
Okay.
what do I teach my restorative dentist? All those things I just told you, meaning shim stock, lateral, all those kinds of things. Here's the difference. Now, the last thing I'm going to do with an upper second molar implant is I'm going to take a leaf gauge out and I'm going to find centric. And I teach this during the courses. And I'm going to make sure when that patient's laying back and they close, at minimum, the implant's not hitting first. Maybe it's the molar in front of it. Okay. So
Okay.
what I say to dentists all the time is, I don't mind if you have a second molar implant. I really mind if you don't know how to adjust the occlusion on it, because you're going to get a future because number one, it's weak bone. And number two, maxilla doesn't move. It's the anvil, the mandible's the hammer. And all of a sudden, bang, 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 every 90 minutes of 2-3 years of micro trauma, the implant tends to fail, or you're going to have a loose screw, or you're going to have something going on. So even in that situation, adjusting the occlusion is a little tricky, because I would prefer you just stay first molar occlusion on an upper, unless you have a virgin opposing tooth and you don't want it to super erupt and things like that. A lot of times, if I get a patient that's going to lose an upper second molar, I say, leave it alone. You're fine. You don't need an implant there,
Hmm.
because of all these reasons.
That makes a lot of sense. It's
Yeah.
probably different too if you're a side sleeper, because that would be like your jaw's relaxing in lateral, and then you hit and
Mhm.
slide to the right or the left, or back sleeper, all that stuff.
Yeah, back sleeper would actually be worse, believe it or not, because they tend to really retrude, right?
Yeah.
Sleep apnea patients, you got to really be careful with them, because they retrude, and that's probably half the cause of their snoring is because their airway restricts, because their jaw goes back, right, in a retruded position. So I try to avoid them. If surgeons want to do them, I get it, but I kind of teach them how to help their referrals, restorative dentists learn how to adjust the occlusion. And it's actually very simple, but it takes some visuals and I show them all this during occlusion programs. So,
Okay. Maybe we could talk a little bit about anterior implants and
yeah.
how do you achieve ideal incisal guidance without overloading it.
Yeah, that's a great one. And ultimately it's almost the same rules, except there's one that's very different. Let's give you the quick simplest example is this. Let's say we're doing an implant at number 8. Same thing. I want a shim stock pull through. The other thing I want is when that patient goes into protrusive or left and right lateral, I don't want any occlusion on the implant. I want all the natural teeth to the mesial and to the distal to take the load. Okay. I know we referred to this a few episodes ago. I also want them to check crossover, right? Which we talked about. And if anybody's interested, they can go back and listen to that podcast. Here's the big one that I get all the time. How do you handle occlusion on tooth number 6 if there's an implant? Because tooth number 6 or 11, you can't avoid lateral excursions, right? Because you're going to want to do some sort of canine rise. So what I learned this many, many years ago from Frank Spear, which was true with even an implant in that position or even a compromised endo post and core on number 6 or 11. What Frank tended to call it is he called modified group function. Now, what does that mean? Okay, Grant, if I'm putting an implant in your number 6,
Yeah.
while we're planning the implant, I'm going to look at tooth number 5. That's the first thing I'm going to do. Now, if tooth number 5 on you is a virgin, beautiful tooth, I'm going to have my lab, when they build the crown for the implant on tooth number 6, I want them to create an occlusion when that patient goes into right lateral where they ride off of 5 and 6, not
Okay.
just the implant. That's why we call it modified group function. It doesn't go any further back than the premolar, but it goes there. Why doesn't it go back further? Because as you go back more posterior, it increases muscle contraction rates and increases a lot of load issues. So we want to keep it as far forward as you can, but you don't want to ride off just an implant. So I say to them, listen, here's what we're going to do. We're going to put an implant in number 6, and we're going to create a beautiful occlusion based on number 5 and 6. Now, here's the other side of that scenario. Let's say we're planning an implant in number 6, and I look at number 5, and you have a huge MODBL amalgam in it. Before they even get to you, I'm going to have this conversation. And, oh, by the way, Mrs. Smith, we're going to do a crown on number 5 when we do your implant on number 6, so that we can protect your implant from failing, because we need to share the pressure or the load so that your implant isn't exclusively taking the load, which can cause an implant failure. I kind of give them, simple terms but it's think like we always talk about from all the other podcasts, what's in it for them. I'm giving them the benefit.
Yeah.
Why am I doing this? And I just quote a total fee. Okay. I don't say, well, we're going to do a crown on this. And then I just say, listen, this case is going to be X amount of dollars. Grant, yours is still going to be the same because you're just dropping a crown and an implant at number 6, but I'm going to be doing an implant at number 6 and a crown on number 5, so that we have good excursions and that the load is shared, so that I don't just have lateral forces on my implant, which is a big no-no. So that's how we adjust occlusion in the anterior. Anything when we go to, let's say it's a 8 through 10 anterior bridge with 2 implants, or even 7 through 10, and with 2 implants and and 2 ponics, you can't take the load off that, right? Because of so when I'm going to go in protrusive, all I'm going to do differently then is I'm going to be really cognizant of making sure that the load is even. Here's another really, really important thing. Imagine this. I have implants in 7 and 10, and 8 and 9 are ponics. Right. I don't want any load on protrusive and right and left lateral on the ponics. I want it only riding on the implants and number 6 and 11. Why? Because ponics flex. Okay. So when I go into protrusive, what I'm looking at is I want protrusive contact on 7 and 10, which is where the abutments are, but I want them to just miss in protrusive the pontics. These are the little details that don't take long, but if you don't know it, you wouldn't know to look for it. And ultimately, here's the problem with those. Those are long-term problems. What do I mean by that? Well, 2 years later, patient comes in, why all of a sudden did this happen? Well, it's a micro trauma, things happen, but because we didn't look at it. And that leads to later on, we may talk about, I don't know how much time we have, how often you check occlusion, you check it, blah, 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 because things change. The mouth is dynamic. The only thing that doesn't move are the implants. So I'll let you keep on going.
Yeah. Is there any, I guess, things that have changed over the years as far as materials / platform switching, like tricks that you've realized using various materials or techniques that can make an occlusion more forgiving on when you're pounding it with forces, or what have you found?
Yeah, I mean, platform switching is greatly, it helped because it actually can reduce bone loss around the edges of the implant. Believe it or not, I think the biggest design difference, and I don't know if every implant company does this, a Morse taper design, believe it or not, and I'm not biased on any implant system, is really good because the abutment tends not to move a lot more. That's one thing. That's that side of things. But I think the biggest evolution has come from, we've switched, and everybody can relate to this, we've switched from acrylic hybrids to zirconia hybrids, right? We're pretty much nobody's doing acrylic titanium hybrids anymore. In my hands, that completely changes the occlusal scheme. Completely. Now, what am I saying? When we were doing acrylic hybrids, and I mean as a final, titanium bar with denture teeth and pink acrylic and things like that, we were still using what all of us know to be a balanced occlusion, meaning it hits evenly everywhere, posterior and anterior, and slightly less in the anterior. I'm not going to go into all that. Why? Because we're talking about a very weak material. We all learned when Grant, when I'm sure you probably remember at some point in your career when you were in dental school, when you did a denture, it was balanced occlusion. I know it's been a long time for you since regular dental school, but that's what it was, right? Why? Because it kept the denture stable. But here was the challenge. All of a sudden, we took this material that was meant to move, which was a denture, and now we made it rigid. Well, the reason we evolved to zirconia is because we had so many breaks, we had so many fractures. So the challenge with that was we still had to keep this balanced occlusion. Now, here's where I find, which is really interesting, that I find that because surgeons in and of themselves, they're not up on everything prosthetically like the restorative dentist hopefully should be. Now we have zirconia. Very, very strong material. So here, and every time I tell this to a surgeon, they're a little surprised, but it really changes everything. You have your provisional in your mouth, whether it's a PMMA, a prototype, whatever you want to call it, and that's still a plastic, a composite, even if it's not acrylic teeth and denture teeth, but it's still a PMMA. When you're doing the provisional, the surgical provisional, you still keep that in a balanced occlusion because it's post-surgical, it's still fragile, it's still, it still has its weak points. So what I would do is when Grant Stucki said to me, Vic, this case is ready to go to final, the first thing I do, I'm not going to go into the details of the digital workflow, but the first thing I do is I'm going to get a new prototype made that has the color I like, the midline I like, all the things that we would always do. Here's the one thing that I do differently than a lot of people. I'm going to equilibrate that prototype from balanced occlusion to canine rise while it's in the patient's mouth.
Okay.
I'm literally probably going to keep that patient in a provisional or a prototype for about 2 months. If they're big and have huge masseters, maybe. I had one guy I left in 6 months. Why? Because I'd rather have them break my provisional than I'd have them break zirconia. Right? Mm-hmm. Fortunately, that guy never broke anything. So what I'm doing is I'm literally equilibrating the case so that instead of going into balanced occlusion, which most dentists hopefully know is when you hit more posterior, you trigger more muscles, which causes more load. So I'm trying to go to canine rise, which triggers less muscles and triggers less load. So I'm probably checking that patient first month once a week, and then letting him sit and then checking them maybe once a month, to the point where if they've never broken my provisional, everything looks good, and I have good occlusion and canine rise, now I'm going to go into my final zirconia with a canine rise occlusion, not a balanced occlusion. Because zirconia is so strong, we don't need that balanced occlusion. And I'm going to do whatever I can to shut off the muscles. And shutting off muscles means canine rise.
Got it.
So this is the only difference that a lot of surgeons, that when I coach them, I say, listen, this is something that we need to consider. It might take a few more weeks of adjusting, but ultimately we're going to go to that. And then I take that provisional and I scan it, and then the lab makes my final based on a canine rise occlusion, not on a balanced occlusion. That's the biggest difference at all. And it's just because zirconia has become so strong, I don't need to use that balanced occlusion in the final at all anymore.
Right. Yeah, that makes sense. How about complications from occlusion? I mean, what are the most common ones you see? Because there's screw loosening, ceramic chipping, implant fracture, abutment fracture, all sorts of things can go wrong from an occlusion that's not properly adjusted. What do you see most commonly?
I think the most common one is what you referred to earlier. Number one is screw loosening without the restorative dentist considering, at least, or a light bulb going off in their hand. It's like, why did it come loose? In other words, I don't want to just tighten the screw and get them out of my office real quick because I don't want to see them again. Meaning, I don't mean that in a negative way. I just don't want to see the same problem again. Right. Yeah. So ultimately, if a patient came to me with a screw loosening, the first thing I'm thinking in my head is, what did I do wrong? Did I not torque it? If I knew I torqued it, now I'm checking occlusion. Yeah. Okay. Because what we don't want is the bad things. Because the bad things are, screw loosening, believe it or not, would probably be the least of the problems. Broken screws are a problem because it's a retrievability problem, and they become a hassle. And then you need a new screw, and the patient loses confidence. Worst case scenario is loss of integration. A very big deal. We all know that, because we lose the patient confidence. You end up taking an implant out, you're regrafting the site, it extends it another 6 months to a year, and it becomes something that is just a challenge because it's something. And I'll cover this at the end, just some little strong points that I really believe. But occlusion is one of the few things in implant dentistry that we can handle. It's completely preventable if we're just cognizant of it. It's not
Okay.
like, all of a sudden something just pops up. It's something that if we would have caught it. Now, that leads me to this. I get this question every time I talk about this. How often do you check occlusion on a patient? Meaning an implant patient that's part of my practice. And they don't want to hear this, but I tell them this every time. Every time they're in hygiene. Every time. So what we do in our office is, I'll have a little morning meeting. And if I know that my hygienist knows to look for cases that are implant cases, and I make them aware that I say this. I say, listen, if it's an implant case, just have some articulating paper ready in the office, in the operatory, on the bracket table, because I'm going to check it. And I don't care if the patient's there every 3 months, I'm going to check it because it
Yeah.
takes me 10 seconds to check something. And ultimately, now I'm going to give you my one horror story. I had this gentleman that was, as you know, Florida is very transient. And I had this one gentleman that was a snowbird. We call them snowbirds. They flew back and forth from New York all the time. And we did some implants on him. But all of a sudden, he disappeared for 3 years. Didn't see him for 3 years. And, whatever, he stayed in New York. And he comes back. And ultimately, he says to me during hygiene, "Oh, my implant's loose. Can you check it?" Well, I know by checking it, I could tell the implant was failing. It wasn't loose.
Dang.
And I'm going, what's going on in my head? What did I do? Here's what happened in his case. It was a premolar. And it was a second premolar. The premolar in front of it, which was a natural tooth, over time had developed fremitus and now was not taking the load. So if I would have seen him every 6 months or 3 months, I would have caught that. And we would have caught it and not caused an implant failure. So, I know this sounds like a little tedious thing, but when you check it all the time, it might take you an extra minute. And if the occlusion changes, because guess what? Here's what happens. The occlusion on the implant doesn't change. The teeth move. So if I can look in hygiene and check it, all of a sudden I see a little bit of occlusions off, I'll move them into my operatory, I'll adjust the occlusion real quick, I'll let them go. But what have I just saved? I've probably saved a broken screw, I've probably saved this, I've probably saved an implant failure. It's a 2-minute procedure to not end up with a long-term problem.
Hmm.
And I did forget to, let's go back to the occlusion and how to set up occlusions, because there's one that's really important, and it refers back to the second molar stuff, Grant. You know how, let's say we're missing that 18, 19, and 20 again.
Yeah.
And we're doing let's say it's a 3-unit bridge. We don't have to do three implants. Here's a very big deal that it gets missed. And this is from a restorative side. What you need to remember when you have implants in 18 and 20, and you're doing a 3-unit bridge from 18, 19, 20, is you have no natural posterior tooth. Correct? Because you're not going to, unless there's a wisdom tooth there, which is rare.
Right.
Now, here's where, when we adjust the occlusion, and what I mean by that is we have no posterior natural tooth. Here's where we can't do that shim stock pull through. Because if we do, that patient, since they don't have a natural posterior tooth to clench into, they're going to clench to get those teeth into occlusion. And sometimes it causes muscle pain. Sometimes it causes a click. Sometimes it causes these things. So what I'm telling you is when you have a posterior implant case with no natural tooth behind it, you can't do the occlusion with shim stock pull through and a clench. You have to give them good occlusion, meaning solid occlusion. Now, what do you do differently? What you do differently on those cases is you narrow the occlusal table down so that they don't have as much. In other words, those 3 teeth, 18, 19, and 20, are going to look smaller than the other side, which are natural teeth.
Okay.
I'm going to narrow it down because if you think about it from an implant standpoint, if I have a an implant crown in 18, and it's a normal sized tooth, the buccal and lingual are almost like cantilevers.
Right.
Okay. So what I want to do when I'm doing a bridge, an implant bridge with no posterior implant, I'm going to give them a good normal even occlusion, but I'm going to narrow the occlusal tables down so that the load is less.
Okay.
What I tell dentists all the time is you need to notify the patient that before you do the case.
Hmm.
Here's what I would say. Mrs. Smith, we want to always protect your implants. These teeth on this side are going to look slightly smaller because we don't want them to take a lot of pressure. Because your teeth on the other side, God gave you, and they can stand the pressure. These don't move. So I need you to understand they're not going to look the same size as the other ones. Why do I tell you that, Grant? Because I had a surgeon up in Boston that didn't say that to a patient, and every time they come into the office for hygiene, she complains about her teeth being too small.
Interesting.
Now, how many people would notice that? Very few. He just happened to be the one unlucky where she was married to a previous dentist and she notices that. But if that
Yeah.
would have been an explanation prior to, and they understand the reason why, it would have been fine. So, those are little things that are super important. Occlusion is never a big thing. It's just a lot of little details.
Yep. That story about the guy showing up, 3 years later, or whatever. Oh, my implant crown's loose. It reminds me, and it kind of brings up the question of what do you say to a patient? Once you've adjusted, you feel great about this occlusion. What are the parting words of instruction to a patient? To watch out for things, to come in. Because I mean, I even say that as the surgeon. I'll say, okay, I uncover it, or check the healing abutment. All right, you're getting the crown next, and I'll give a spiel about, this crown is not going to be like your regular teeth because we're fused to the bone, and so it's got to be shorter, and your dentist knows that. But if at any point it becomes sore, it's kind of aching, if it's loose, like those are all red flags that you need to get that tooth adjusted. So come in, don't just let a tooth be loose for months and months, because that's when we get an implant failing. I mean, and so I'm always kind of struggling to know how much to say, what to say so that the patient at least has some red flags in their mind to say, oh, I got to go get that checked. What do you say?
Well, two things. Number one, everything you just said is very important. But number two, and this is a little touchy spot with some dentists, is when I do implant cases, I don't care if it's 2 implants or 12. Their hygiene protocol changes for me. What do I mean by that? And we can talk about what I do for full arches, whatever. But here's what I mean. I want those patients in hygiene every 3 months. 2 reasons. Number one, they think these titanium screws are invincible and they're never going to have a problem. That's one thing, because nobody ever tells them what you just said, Grant. And number two, I want to constantly check the occlusions. Number three, how many times, Grant, have you seen somebody where you tell them they grind and they look at you and they go, no, I don't. I don't grind. I'm not a grinder. If I was a grinder, my wife would tell me I'm a grinder. Well,
Exactly.
it's just silly, right? And because I'm looking at all the other teeth and you see all this wear and they go, you grind. They go, no, I don't. And I'm not going. So, and if I see a severe case, I actually put the fear of God into them. Here's what I mean. You grind. You made a big investment in the implant. I need you to wear a night guard at night. And if you don't wear it and your implant fails, that's going to be a big problem and it's going to be very expensive. Notice I didn't say I'm going to charge you again, right?
Yeah.
I told them it's going to be very expensive. So I'm really just trying to put the little fear into them that's saying, call me if you have a problem. Call me if it feels loose. Come in for hygiene every 3 months. Let me check the bite. Wear your guard at night. Because if you don't and something happens, it becomes an expensive problem.
Yep.
I'm just being very subtle and saying, I'm going to charge you again. Okay. So ultimately, it's one of those situations where one of the few places where dentists, even though sometimes they're uncomfortable with it, they have to be more proactive.
Yeah.
The old adage is, if I tell you beforehand, it's information. If I tell you afterwards, it's an excuse, right?
Right.
And God bless you for really being proactive and giving them information. But the problem with with you as the referral or the surgeon is once they leave, you still kind of lose control of that situation, right?
Yeah,
You know,
for sure.
and those kind of problems become not only very expensive, they become multiple problems because then they have to see you again, they have to see the restorative dentist again, and it becomes this big, to do, and it's not a fun situation. So, and nobody likes a redo.
Exactly. Yeah, and it reflects poorly on all of us. I mean, if a if a crown fails or it's occlusion, usually they think it's the implant underneath was bad, and it's the surgeon's fault. So I mean, I'm trying to do everything I can to make that crown successful and well adjusted, and then all that stuff. I mean, because I think oftentimes we think, oh, a patient, if it's sore after a few weeks, they certainly would know to go back and get it checked, or if it's loose. But it's just wild to me how a patient will come in after like 2 years and be like, oh yeah, the crown's been loose ever since they put it on. And it's 2 years later, and you're like, what in the world, man? How could you
Well,
not?
and that's part of that. Grant is not even your fault in the sense where sometimes they're in hygiene in a restorative dentist office, and the dentist says, "Well, if it's not falling, wait till it falls out, and then let me know." I mean, that's a huge mistake,
Yeah,
right? Because if it's loose and now all of a sudden the screw breaks, now we have a bigger problem. If it becomes, the tissue becomes irritated and you have inflammation and you have bacteria there, it becomes a bigger problem. So it's this situation where I would be much rather be proactive and do exactly what you said. Listen, if there's, and maybe you and I should create a handout. Here's, like we did with the laterals. Here's all the signs to look for a patient sample. All the signs to look for these. If something happens, call us. If something happens,
yeah,
come see us. If something happens, do this.
yep,
And then I want you to get cleanings every 3 or 4 months, and we're going to check your bite every time, because ultimately the value of information before something happens is much more valuable than trying to scramble and figure out why did it happen, and now the patient loses confidence, and that's what we don't want. We don't want and I've said this to you kiddingly, Grant, but it's so true. If I was a specialist putting implants in, I'd be a nervous wreck. I'd probably be on Valium every day because I'd just be thinking everybody's doing occlusion differently, and I don't know if these are going to work or not work and things like that. And I know the surgeons, as being a really good service-oriented business, you try to take that into your own hands sometimes, and I get it. But sometimes after a year or two, that's gone, right? And now when a problem happens, you're still dealing with it, and that's not fun.
yeah. Well, this has been really, really helpful for me, and I think our listeners will benefit. So if you could distill this down to a couple pearls, like main points about occlusion, to the surgeon and the dentist who's adjusting it or creating the occlusion, what would you say are those top 2 or 3 points?
Well, number one, if you can remember a really quick sentence is this, and this is just my trying to think of my way of putting this. My skepticism is, and I believe this in a lot of things, never trust, verify everything. Everything else is just noise. Meaning, I thought the screw was tight. I thought this was good. One of the things we didn't even refer to, and I know we mentioned a little bit, is are you even looking at the opposing tooth above your implant? Is it super erupted? Do you have to adjust the occlusion? Do you have to do these
Yeah,
kinds of things on these levels so that setting up the case gives you more, insurance? And then lastly, too, are you looking, and this is something when you start doing, in my hands, when you start doing full mouth rehabs, whether it's implants or not, and you look at this case, and this is where I think we're going to get in trouble in dentistry, implant dentistry. You look at the case, and all of a sudden, the guy's, or man or woman has just worn their teeth out. They're grinding, they're broken. And I look at it and I go, your past history is an unbelievable indicator of what's going to happen in the future. So when I'm planning a case, if I see a case and I need an implant in number 30, but everything else is just blown out, I'm going to go, I think I need to plan this differently,
yeah.
as opposed to let me just fill that hole with number 30. And then
Hmm.
ultimately, even in these simple cases, if you're constantly verifying the the occlusion. And here's what and dentists don't want to hear this because it kind of puts the onus on them. But probably 95% of implant failures, other than cement failures, are occlusion issues. Goes back to what Carl said. And here's the amazing thing about those. All of them are avoidable.
Hmm. Very
And it's just
interesting.
a
Yeah.
matter of the little things that you do that are different than anybody else. So that little, and you can imagine that implant's just sitting there going, protect me. And what are you going to do about it? Because the implant doesn't know who's on the other end of it, right?
That's right.
The implant doesn't know that Grant put the surgery in or I put the crown on it. And it's not a coincidence, and I'm sure you probably see this and you may not want to admit it. There's probably more failures from some restorative dentists and other restorative dentists and things like that. And ultimately, why? Because we kind of maybe all doing the same thing sometimes. And trust me, I'm not, how did I learn all this? Trial and error. I learned it through listening to a lot of great mentors that were much better than I was. And what I learned, for example, that one that I told you about where the implant failed because the tooth in front of it was frematous. From that point on, I go, listen, I need to see you at minimum every 6 months. If you're going to be living in New York, then I can't take responsibility for that if you don't come back in a year. I just can't do that. Because if your other teeth move, and let me leave you with this as well. And you probably see this all the time. Patient gets an implant. Now all of a sudden another tooth gets broken and they need another implant. Here's what most dentists don't think about. The minute you take another tooth out and you put another implant in, the occlusion changes.
Yep.
Every time.
So
It's
true.
like a domino effect, right?
Yeah.
Recheck it. That's all I'm asking. I'm not saying to, do a full mouth rehab. Check the occlusion because this is the one thing that's the most common cause of failure or a complication, but it's also preventable.
Yeah.
Right? And then full arch cases, I think we're going to see a lot of problems in the future because I think there's a lot of cases that the occlusion is not handled right, the bone's not handled right. But we could talk about that for a whole nother 2 days. But I don't want to keep you, so we can leave it wherever you want.
Yeah, that's been really helpful. And just piggybacking off what you just said, I literally say that 100 times a day. It seems like just this morning, I'm taking out tooth number 19, and I say, the plan's the bone grafted, and we're setting this up for an implant. Are you planning on doing that? I'd highly recommend it. And yeah, a lot of patients, even with these, 19, 20 really important teeth, they'll go, I don't know. I'm just going to see how it goes. And I'm like a broken record to say, it's so important to get this back because we're kind of creating a domino situation right now when we're going to take this tooth out because this tooth has been taking a lot of force. And now all the force on that tooth is probably getting spread on these smaller teeth next to it, 20, 21. We don't want those teeth to be stressed and to chip and crack over time because this one came out, and how important it is to get that implant and occlusion restored to where it was. And I just constantly belaboring that point of like, we're trying not to create a domino. Take one out, now then 6 months later, now 20 is cracked in half, and that's got to come out. We're like, oh my gosh.
Well, it's interesting that you said that because I find this when I do my treatment planning sessions or, what we refer to previously as grand rounds. I'm constantly asking this question during our treatment planning, and very rarely do I get an answer. And here's the one question that's so simple that dentists don't ask. What you just said, let's say it's number 30 or number 19, and it cracked and you put an implant in, right? Why didn't the dentist ask, how did it break?
Exactly. What's the process going on?
In other words, if it broke because you bit into a juji fruit or a gummy bear, okay. But if they look at you and they go, I don't know, it just broke. And you think you're going to put an implant in and it's going to be okay?
Mm-hmm.
That's the definition of insanity. It's
right.
Like, seriously? It's like, let me just fill the hole and not do anything different and expect it to be okay. Yeah. But that explanation from you is so helpful because at least it helps patients understand that the minute you take a tooth out, like you said, number 19, guess what? You're probably hitting on 18 harder now.
Yeah.
Right? Or whatever tooth, or maybe it's the opposite side. Very few, unfortunately, patients or dentists understand that it's just all the, and going back to, and we'll leave it at this, going back to the very beginning of what we talked about at the definition of occlusion. The minute I share load evenly, nothing happens.
Mm-hmm.
The minute I change load sharing, something else happens.
Yeah, good point.
And sometimes it's just a sensitive tooth, or whatever or tooth shifting, and sometimes it's something dramatic. But we have to make sure that we're looking at what I referred to earlier as, what if I do this and I don't change something? If I always look at everything with a what if standpoint, I'm probably going to have far less problems. And all I want for your surgeons and your listeners is to be able to feel comfortable putting implants in and helping your restorative dentist understand occlusions at the level where you're not dealing with the complications.
Yeah.
And they don't want to deal with them either. It's never fun. So
For sure. Well, this has been fantastic. I think it's a much underestimated topic, especially for us as surgeons to talk about. We start losing attention real quick when you start talking about occlusion.
Most people do, Grant, even the restorative dentist. So that's okay. A good way to put somebody, if you're having insomnia, I'll give you an occlusion book. You can read it for about 15 minutes, and you'll be. I'm an occlusion nerd, so I don't know what it is. I'm a little strange, but that's life.
Well, I love the discussion. It's so helpful. I mean, it impacts all of us, whether we like to admit that or not, and the success of the implants and how our surgeries and our practice is perceived is so dependent on how well that crown is adjusted. So I appreciate you sharing these pearls, and look forward to keeping it going.
If your listeners have any questions, you can put my cell phone on there, Grant, and then my email. If they ever have an occlusion issue, like they have a problem with a particular case, I'm always open to answering. You know me, I get back to people pretty quickly. So if they have an occlusion issue where they're having a problem with a certain case, I'm more than happy to help them with it. I just want them to have a better time doing dentistry than worry about solving the problems all the time. So
yes. Well, thank you for being able and available to do that. So appreciate you.
All right, buddy. Great talking to you.
Rest of your day. Same. Talk to you later. Bye. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.